Hello and welcome everybody. This will be the webinar on women's involvement in HIV research. My name is Christina Antoniadi and I'm the EATG for Women Portfolio Coordinator. I will also be moderating the webinar today. So we have some technical information before we start. Christian? When you join the webinar, all your microphones are muted. If you want us to unmute your microphone, you should be able to see a hand in the upper right-hand corner, which you have to wave in order for us to unmute you, or you can send us a message with any questions that you might have. This slide is fantastic. It shows you exactly where the question thing should be. My screen is very different, so I'm not saying exactly the same thing. But don't hesitate to try and make a contact if you have any problems. So this will be the first of a series of 4 webinars that will be carried out under the project Metro Dora. How did we come up with the title? Metro Dora was a Greek female physician and author of the oldest medical text known to have been written by a woman. It was called On the Diseases and Cures of Women. She is generally regarded as the first female medical writer. Our Metro Dora, accordingly, is a project that aims to meaningfully engage women in HIV treatment research. And how do we plan to do this? The project has 3 components. In the first, we conducted a desk research and we will present the findings of this in a future webinar. Our goal was to identify if indeed there was a significant proportion of clinical trials recruiting small numbers of women, if any, and to investigate possible legal and other barriers that prevent women from participating. In the second phase, we will conduct a series of 4 webinars. This is the first one, and a face-to-face training for 15 participants in an effort to widen the knowledge levels of people who are interested in clinical trials and research, ideally women living with HIV, but also activists and professionals who have an interest in women's participation in clinical research. In the third phase, we will hold a stakeholders meeting where community researchers, policymakers, international organizations, and pharmaceutical companies will come together and hopefully come up with an action plan that will enable us to improve the position of women in clinical trials. Today, as we examine the women's participation in clinical trials, we are very happy to have with us an expert on this field. In the next slide, Christian, you can see our website address, and also Metro Dora, the project has a resource section, so you can find more information about clinical trials and women's involvement in clinical trials. Today with us is a woman who has conducted a lot of women-specific research in the HIV field. Shema Tariq is here to deliver the webinar. Shema is a Postdoctoral Clinical Research Fellow at UCL Centre for Sexual Health and HIV Research and Honorary Consultant at Mortimer Market Centre. Her main area of interest is the reproductive and post-reproductive health of women living with HIV. Shema is currently the Chief Investigator of the PRIME study, an NIHR-funded study investigating the impact of the menopause on HIV-positive women's health and well-being. For those of you who don't know what NIHR is, it's the UK's National Institute of Health Research, and it's very difficult to get funding from there. Shema has a particular interest in improving the representation of women in HIV research, and she is also very community friendly. She has been of tremendous help to us for this project, and the guidance she has provided this far is very much appreciated. So, Shema, if you're ready, we can start.
Thank you, Christina, for such a lovely welcome. So, hi, everybody. I'm speaking to you from a very rainy London. I'm very excited to have almost an hour to talk about women's participation in HIV research, which is something that I think is very often overlooked. Next slide. So these are just my conflicts of interest. Next. So in the next 40 or so minutes, we're going to be covering a lot of ground. I'm going to be talking to you a little bit about the background to this talk. So giving you an overview of women and HIV, both globally, but also talking about some of the UK specific data. I'll then be talking about the representation of women in HIV research. So what do we know already? We're going to ask ourselves, why does representation matter? Should we care that women are represented in HIV research? We'll then move on to discussing the potential barriers to women's participation, and finally move towards setting an agenda for change. So how can we improve women's participation? Next slide. So just so we're all on the same page before I start, I'm going to be talking about HIV research. And by that, I mean all types of research, from the laboratory through to drug trials, through to social and behavioural research. You'll notice throughout my presentation that I'm not going to refer too much to PrEP. That's not because I don't think it's important. It's hugely important, but I feel that that's worthy of its own presentation in itself. Secondly, when I talk about women, this is an inclusive term. I'm talking about both cisgendered and transgendered women. However, at various points, I'm going to tease this apart because there's certainly going to be issues that affect both those groups of women differently. Next slide. So let's start off by thinking about women in HIV. Next slide. So I'm going to leave this slide up here just for a few seconds for you to take that in. So over half of all people living with HIV around the world are women. And I think that's something that we often forget. Next slide. The other thing that's really important to remember is that the prevalence of HIV in women varies globally. So although I say that over half of women, half of people living with HIV globally are female, the epidemic is going to look very different from region to region. So certainly sub-Saharan Africa has the highest prevalence of HIV among women. You can see that represented by the large circles. Now, if you look in the top left-hand corner, you're seeing the European data where the circles are smaller. However, it is really important in the European and Central Asian region to remember that there are important emerging epidemics in women, certainly in Russia and throughout Eastern Europe. Next slide. Again, HIV is still the #1 cause of death in women of reproductive age. Next slide. So I'm now going to move towards to looking at data from the UK. So this is data from Public Health England, looking at women attending for HIV care over a 10-year period from 2006 to 2016. So firstly, what you can see if you look at the general shape of the bars is that there's been an increase in the number of women accessing HIV care over a 10-year period. Now, I want you to first of all look at the blue-green bars that are just at the bottom of the bar chart. These are women who are under the age of 35, and what you will see is that the proportion of women attending for HIV care who are younger is decreasing over time. Now, if you focus on the bars above that, so this is the orange, the red, and the brown bars, you'll see that those aged 35 and over are increasingly making up the majority of women living with HIV, attending for HIV care in the UK. So what does that mean? It means that not only should we be focusing on women's health as they live with HIV, but particularly we're going to have to start focusing on the needs of those women who are older and living with HIV. Next slide. And how about transgendered women? So we know that the prevalence of HIV amongst trans women is about 19%. This is from a meta-analysis published in 2013. However, that this prevalence varies globally. It is estimated that trans women are 49 times more likely to have HIV than any other group of adults, which I think is a sobering statistic. Next slide. And why is this important? So again, this is data from the UK on trans people living with HIV. So this is data from Clinic Q, which provides a holistic sexual health care service to trans people. Here, what you can see is the intersection of other factors with having a transgendered identity. So being from a minority ethnic group, working in the sex industry, use of recreational drugs, and a 16% history amongst 32 trans women that they surveyed attending their service, 16% history of sexual violence. Now, if we look at the HIV outcomes, what we're seeing is that about 80% of trans women attending their service achieve an undetectable viral load, which is something to be celebrating. However, this compares to 96% of non-trans people living with HIV attending the wider service in this NHS trust. Also, interestingly, nearly a third of women in this survey had reported a treatment break. So this certainly points to differential treatment outcomes amongst trans women. Next slide. So let's start thinking about the representation of women in HIV research and what we know so far. Next slide. So this was a systematic review conducted in 2013, and this is a review of 15 high-impact journals in a short period of time. So the authors here really only looked at 15 journals published between January and March 2011. What they found in this snapshot analysis is that only 38% of study participants were women. 81% of the studies that they looked at did not mention pregnancy. So these are all studies to do with HIV. Now, this is the majority of studies did not even mention pregnancy. So we don't know if pregnancy was accounted for, whether it was recorded, whether it was looked at. And if you look at even closer, where pregnancy was mentioned, only 4% of participants were pregnant. So what does this mean? Well, it means that not only are women underrepresented, but it also means that we have huge gaps in data on pregnancy and HIV in these studies. Next slide. So this paper that was published in 2016 is probably the most widely cited paper when we look at the inclusion of women in HIV research. So these authors did a really ambitious and expansive search of the literature. They reviewed 544 studies published between 1994 and 2012. And what they again wanted to do was document the proportion of women represented in these 544 studies. And they looked in particular at antiretroviral studies, vaccine studies, and cure studies. And what they found was that women were only represented 23% of all participants in those 544 studies. So remember, one of the first slides I showed you is that women represent over 50% of the global burden of HIV. When we actually systematically review the literature that we have on HIV, women represent just under a quarter of participants in clinical research. What is important to note is certainly this representation has increased over time, but certainly not to a level that we would say is equitable. Next slide. So this is digging a little bit deeper into that paper by Kerno et al. Published in 2016. So as I mentioned, in this particular review, they looked at antiretroviral studies, vaccination studies, and cure studies. And what they also very interestingly did was look at the proportion of women compared to men in each of those different types of studies. So again, what you're seeing is this same pattern of low representation or underrepresentation of women compared to men in all groups. But where women are even more underrepresented are in cure research and also antiretroviral therapy research. So antiretroviral therapy studies, 19% of women were in those studies. In cure research studies, it's 11%. And in the vaccine studies, it's higher at 40%. So Why it's reasonable to ask why is there such low representation, in particular in cure research, but also antiretroviral therapy. So I would say, I would hazard a guess that a lot of that is due to ongoing concerns about using investigational agents, so agents that haven't been trialled, among researchers and women themselves, especially women's concerns or researchers' concerns about pregnancy and the effects to an unborn child. But I'm going to go back and revisit that later in the presentation. Next slide. And what about trans women in HIV research? So there really are not much data in this area at all. It is widely accepted that trans women are underrepresented in HIV research generally. Unfortunately, trans women are often misreported and often conflated with men who have sex with men. So if you look at some of the early PrEP studies, for example, transgendered women and men who have sex with men were all lumped into the same category. This is important because, of course, this not only elides a fundamental aspect of someone's identity, but also means you can't differentiate outcomes between very different groups of people. Certainly, I think trans women are often undercounted in research, and that can be due to the fact that trans women aren't allowed to self-define their gender identity when they participate in research. And looking particularly at a UK setting, I'm not familiar with settings outside of the UK in this area, I'm afraid. There appears to be a paucity of UK data on trans women in HIV, so we really don't have much in this area at all. Next slide. But how can we look at the broader picture? So it's important to recognise that this picture that I'm building of underrepresentation of women in HIV research reflects a broader problem in society, which is that women are underrepresented in health research in general. Women are underrepresented in lots of social spheres in general, or lots of spheres, public spheres in general. So I think what we're seeing in HIV reflects a broader issue of gender bias in clinical research in general. Next slide. So here I'm really highlighting some data from Paula Johnson, who's done some really fantastic work over in Boston, looking at representation of women in clinical research in general and gender bias. So if we start with the top, we know that cardiovascular disease is the #1 cause of death in women. We often talk about things such as breast cancer, which of course is important, but actually numerically cardiovascular disease affects many more women. However, when you look at the cardiovascular disease trials, women only represent 1/3 of those in cardiovascular disease trials. Again, looking at lung cancer is another example. So lung cancer is the leading cause of cancer death in women. Also, another important difference is that women who are non-smokers are more likely than non-smoking men to get lung cancer. So it appears that lung cancer behaves differently in women than it does in men. However, women are much less likely than men to participate in lung cancer trials. The majority of lung cancer trials are in men. And then finally, we know that depression affects twice as many women as men. But again, 45% of participants in studies of depression are women. And in fact, that's skewed. It should be many more women in depression studies than men. Next slide. So I hope what I've done over the past few slides is start to really form this picture of the underrepresentation of women, not only in HIV research, but also in medical research in general. So why should we care? Why does it matter that we represent women adequately in medical research? Next slide. So I hope what I'm going to do in this talk is convince you that better representation of women in HIV research equals better science. And if you take only one slide home with you or remember only one thing from my talk, try and remember that. Next slide. So this is a diagram showing the social ecological model of health, so drawing upon this framework to look at factors that may impact women's risk, but also their experience of living with HIV. And I'll just walk you through this slide. And the main thing to see here in this slide is this move, or the move from both individual level factors, interpersonal factors, community factors, and structural factors. And what I would argue very strongly is when we're looking at any aspect of HIV in women, what we're looking at is a complex interplay of all these levels. So at an individual level, we're thinking about a woman's biology, her knowledge, her attitudes, the skills she may have, her self-efficacy, for example, her ability to take medication, and stigma. At an interpersonal level, so this is how women may function amongst their immediate social circle and with their partners. Things that may impact a woman's experience or risk of HIV include relationship power and satisfaction, intimate partner violence, and social support. Going up a further level, we look at community level factors such as cultural norms, stigma again, social capital, the local environment, and cultural norms. Sorry, I've put that in twice. And finally, at the structural level, we have poverty, policy, legal frameworks within countries, and gender equity. So really, when we're looking at a woman's experience or risk of HIV, it can't be boiled down to one cause. However, it is really important to, if we go back to the individual level, to remember that biology is also important. Next slide. So about 15 years ago, the American Institute of Medicine made this statement: every cell is sexed and every person is gendered. So biologically, we know that there are sex-driven differences at a molecular and cellular level. So sex-wise, men and women differ from each other at a fundamentally biological level. This means that our organs are fundamentally different and they work in different ways. However, related to that, it's also important to remember that sex is not the same as gender, and that gender and the experiences and factors associated with this do not directly map onto biological sex. So when we're looking at research, we need to account for both things, both sex and gender. Next slide. So the next thing I want to put to you, when we're thinking about the biology of men and women and the differences in terms of gender, that the treatment of HIV is overwhelmingly based on research that has been conducted on Caucasian men. And remember that over half of all people living with HIV globally are female. You'll get very bored of me going back to that same statistic, but I don't think it's ever too much to hammer that home. Next slide. So let's think a bit more about the biological differences in terms of HIV between men and women. We know that cisgendered women are 2 to 4 times more likely to acquire HIV than cisgendered men. And this is even more so in trans women. This risk is even greater, as I pointed out a few slides ago. Now, why is this? This could be due to greater mucosal surface, so there's greater tissue surface in the vagina. Could be due to the vaginal microbiome, so that's the vaginal floral environment. Could be due to tissue injury during sex. And with trans women, there are particular considerations around the neovagina and how that might either increase or decrease risk of HIV acquisition. The second thing to take into account is the hormonal environment. So if we think about, and certainly hormonal transitions, so women during puberty, during pregnancy, and also during the menopause, and how that may impact both their risk of comorbidities, but also the metabolism of certain drugs. And finally, it's important to remember that women can present with different symptoms. So I think a classic example of this is with heart attacks. women are much more likely to present with what we call atypical signs of heart attacks. And those signs are jaw pain, arm pain, shortness of breath, nausea and vomiting, whereas men are more likely to present with chest pain. So clearly there are bodily differences between men and women. Next slide. And what about HIV outcomes? So this is data from a few years ago from the UK, looking at virological suppression. So comparing men and women in terms of the percentage that achieve virological suppression. So these data are a bit old, and you can see that in general, about 80% of men and women are achieving viral suppression. It's much higher now in 2018. But really, the take-home message from this slide is that there's no real difference in terms of rates of virological suppression in men and women. Next slide. But actually, when you dig down deeper into these data, you'll see that there are differences in terms of antiretroviral therapy. So this slide shows the percentage of men and women who discontinue treatment or switch their antiretroviral therapy after starting. So you can see the top line, which represents women, the grey line, there was a greater proportion of women at every time point who had switched or stopped antiretroviral therapy. Now, in this analysis, interestingly and importantly, they did adjust for pregnancy. We know that in the years that these data were from, practice would have been for short-term antiretroviral therapy, so temporary antiretroviral therapy during pregnancy. And the researchers did think, well, could this account for these switches or stops? So they took the women who were pregnant out of the analysis and still found the same thing. So why could this be? Well, one thing to think about is the potential side effect profile in men compared to women. Next slide. So you'll be glad to know that I'm not going to go through this very complicated pharmacokinetic slide in great detail. But what I really want to do is just highlight the possible differences in how antiretroviral therapy may work in men and women. So firstly, if we look at bioavailability, there can be differences in terms of absorption of drugs. So women, for instance, may have slower gastric emptying, which could lead to a reduction in drug levels, and this is usually due to hormonal effects. If we look at drug distribution, women are likely to have lower weight, which could increase levels, but they may also have increased fat, which decreases levels. Moving on to metabolism, so for instance, we know that men have higher levels of hepatic PGP, which is a type of drug transporter which facilitates elimination of drugs. So that may mean that women have higher levels because they have decreased elimination. And again, moving on from that to elimination for other reasons, so women are likely to have smaller organs, which will have an effect on drug clearance. So clearly, there are biological differences in how men and women process antiretroviral therapy, and that could start pointing to why antiretroviral therapy may have differential effects. Next slide. So what are the data in side effects in men compared to women? So firstly, it's really important to point out that there are very few analyses for side effects of antiretroviral therapy that disaggregate or differentiate by gender. We know from the studies that have been done, the few that have been done, that the side effect profiles are similar in men and women. So it isn't that women are getting different side effects, but they seem to have differences in both frequency, presentation, and severity. So, for instance, we know from studies that have been done in nevirapine and etraverin that women are more likely to have a rash. Women are more likely to get liver abnormalities as a result of using nevirapine. One of the studies that looked at darunavir-ritonavir in women, which I'll be coming back to later, did find that women were more likely to have increased anthropometric measurements. So this is increased large. They were more likely to have larger increases in BMI and waist circumference compared to men. Although it's important to note that men have more changes in lipids than women, so it kind of balances out. And more recently, women were more likely to have adverse effects with Truvada, atazanavir, ritonavir compared to Triac as compared to men. Next slide. But the other thing to also point out or to remind ourselves of is that cisgendered women certainly experience certain biological and social events that are going to pattern both their outcomes and the experience of HIV. So that includes puberty and having to think about the risk of pregnancy. It includes pregnancy and thinking about the effects to the unborn child, breastfeeding, and also menopause. And we still don't know how these things impact HIV. Well, we won't know how these things impact HIV unless we include women in the studies. We have no way of knowing how menopause affects antiretroviral therapy unless we include women of menopausal age in those studies. Next slide. And thinking about other factors, so this is looking at comorbidities and the outcome of cardiovascular disease in women living with HIV compared to men. So this is very recent data from the DAD study, which is a European study. So DAD have looked at data in both men and women. So this is a forest plot. Basically, the further to the left the markers are, the less likely women are to have one of these interventions. So these researchers are looking at comparing men and women's use of cardiac interventions in HIV. So at the top, you're looking at lipid-lowering drugs, and you can see, so in the brown, these are the adjusted analyses, which you should focus on. So at the top, women, because they are more towards the left, are less likely to have lipid-lowering drugs. Next line is the ACE inhibitors, which is a type of blood pressure tablet. So there is a slight difference, not much. When we're looking at antihypertensives, which is the next line down, this is blood pressure medication. So here they're not seeing, they're seeing that women are more likely to be using antihypertensives. So you can see that brown mark is to the right. And then finally at the bottom, this is invasive cardiac procedures. So this is things such as angioplasty. And you can see women are much less likely when they have an indication to have had an invasive cardiac procedure compared to men. So really what this diagram is showing you is that cardiovascular disease is undermanaged in women living with HIV compared to men living with HIV. This is not a new finding. In the general population, women are seen to be undermanaged for cardiac risk factors, regardless of HIV status, compared to men. Next slide. And what about the other factors that may impact HIV in women? So really just thinking back to that social ecological model I showed you before, I've been focusing a lot on the biological differences, but we cannot forget the social. So things that may impact women differentially: socioeconomic disadvantage, the fact that women are more likely to have caregiving responsibilities as a result of gender norms, the experience of gender-based violence, stigma, sex work, mental health issues, including drug use, and incarceration, which certainly has differential effects on women compared to men. Next slide. So here I'm presenting data from the ASTRA study. The ASTRA study is a questionnaire study that was conducted amongst people attending for HIV care in 8 UK HIV clinics. So they have data on about 3,000 people living with HIV, about 600 of their participants are female. And really, I just want you to look at the left-hand side graph, which is looking at non-adherence to antiretroviral therapy. So you can see, so here we have women compared to men who have sex with women and men who have sex with men, and you can see that there's a greater proportion of women who report non-adherence to antiretroviral therapy compared to the other two groups, and this was significant when adjusted for. Next slide. So really my argument beyond better representation equals better science is that better representation of women in HIV research is an equity issue. I've shown you some differential outcomes in terms of comorbidities, side effects, adherence. If we are to achieve equitable outcomes in both HIV prevention and treatment, we must address gender bias in HIV research. Next slide. So we're now going to move on to thinking about the barriers to women's participation in HIV research. Next slide. So I think it's really important to take a step back and think about historical perspectives when it comes to medical research in general. So this diagram is really showing you just the trajectory of general medical research and its attitude towards women. So for much of the 20th century, men were seen as the norm. It was seen to be irrelevant to conduct research in women because, of course, their bodies would be the same as that of a man. Also, women were seen as more complicated because we have fluctuating hormones, and that makes apparently it very complicated to study drugs in us. In the 1960s, there was the thalidomide scandal. So for those of you who are not aware, thalidomide was a drug that was widely used by women, certainly in Europe, to prevent morning sickness, and it resulted in severe congenital abnormalities, limb abnormalities. The thalidomide scandal led to widespread fears about the use or the trial of new investigational agents during pregnancy and effects on the fetus. This led to, in the 1970s, pregnant women being classed as vulnerable subjects and excluded from drug trials. This is problematic because it means not only do we have very little safety data of all types of drugs, not just HIV drugs in pregnancy, I think it's also problematic categorizing pregnant women as being vulnerable and not allowing them to make informed choices about their willingness to participate in research. At this time, there are also restrictions placed on women of reproductive age. So you will find that in a lot of research in the 70s and 80s, 90s, even more recently, women of reproductive age were either excluded or there were very stringent conditions about the use of dual contraception. So lots and lots of fears around the potential effects to the unborn child. In the 1990s and 2000s, there was increasing recognition of the important differences between men and women. Certainly in the 1990s, the American National Institute of Health made a move towards explicitly stating that women needed to be included in medical research and that researchers should present data on the proportion of women recruited. And then in 2001, the Institute of Medicine released their statement, "Every cell is sexed," which I think has really been a game changer in understanding that good science needs to differentiate between men and women in terms of clinical research. Next slide. But I wanted to think about barriers in particular to HIV and what are the barriers to women's participation in HIV research. So I did what every person should do when they've got a question. I asked some friends. Next slide. So I'm lucky enough to be friends with and have a great number of fantastic colleagues who are living with HIV, who are women, who answered this question. So I asked them, what do you think are the barriers to women's participation in HIV research? So these are the answers from my friends, but also supplemented by some ideas from the Kerno et al. Paper, the meta-analysis I presented earlier. So certainly there seems to be a lack of research literacy amongst women living with HIV. So a lack of awareness of what research is and what the potential benefits could be. There is a long-standing fear of being guinea pigs and of being experimented on, and many of those are founded in understandable concerns about stigma and discrimination within the healthcare profession. There are clear logistic barriers for women. Childcare, clinic hours, and transport costs can all be an obstacle to participating in HIV research. Multiple concerns about stigma and confidentiality, wondering what will happen with the data. I think we have to take into account the importance of gender norms and gender inequality. So who makes treatment decisions within a relationship? Is a woman free to make a decision about participating in a trial, or is this something that is it that this would be a decision that would be expected to be made on her behalf by her family or by her partner? One thing that I think is often neglected, which I'm very keen to highlight, is the potential role of researcher bias. I certainly I do a lot of work with women living with HIV. Most of my research has been in this area. It is not uncommon for me to hear from other researchers or other doctors that it is difficult to recruit women living with HIV into HIV studies. I can categorically state that's not the case when you do it properly. And in terms of other barriers, I just wanted to highlight that there is further research in progress to try and understand the barriers to HIV research for women in particular. So I'm currently involved in a study called POWER, which will be looking at the barriers and facilitators to participation in research amongst cisgendered women here in the UK. So we will have some more UK specific data within the next year or so. Next slide. And here I think it's important to particularly think about the barriers specific to trans women, because I do think there are particular barriers amongst this group. So again, these points have come from published literature, but also from a fantastic event organised by Juno Roche, who's a prominent trans activist and writer, who organised a great roundtable event to really try and unpack what the barriers were specific to participation, barriers to research were specific to the trans communities. So I'm really drawing upon a lot of what we discussed at this roundtable. So firstly, there's a perception or feeling that because trans women comprise a relatively small proportion of the population, they're small numbers, that means that there's a lack of funder interest. People don't want to fund research that affects only a small proportion of the population. There is a lack of trans-led research, and I think this is something, again, I'll be coming back to, the importance of community-led initiatives. Fears of stigma, a fear of not receiving gender-affirming care, so being misgendered or perhaps being asked inappropriate questions by healthcare professionals, having had that experience before. Concerns about drug-drug interactions, so specifically trans women may be concerned about going on an antiretroviral treatment trial if they're on hormones for their medical transition. And I think also other things to remember is that sometimes in research that has been done, there hasn't been accurate recording of gender identity. And also when there have been data that have been collected from trans women, sometimes they've been excluded from reporting because they seem to be small numbers. So lots of things that I think have led to the underrepresentation of trans women in HIV research. Next slide. And really just to close this section is to ask you to think about intersectionality. So intersectionality or intersectional approaches takes into account the complex ways in which multiple forms of discrimination overlap or intersect with each other. So things such as ethnicity, age, ability, class, sexuality. And to remember, when we're talking about women's representation in research, we're not just talking about gender, we're talking about the intersection between gender and all these factors that I've mentioned. Next slide. So for the final few slides, I really want to start thinking about an agenda for change, and I'm really looking forward to the questions and discussion that we're going to have at the end of this webinar. Next slide. So firstly, I want to say that there has been progress. Increasingly, we're seeing a focus on women in antiretroviral therapy studies. So for instance, in 2011-2012, we had GRACE, which was looking at darunavir, ritonavir in men and women, so it compared outcomes in men and women. More recently, we have had WAVES, which has looked at Truvada, cobicistat, and elvitegravir versus Truvada, atazanavir, ritonavir. ARIA, which has looked at Triamec versus atazanavir in women. And finally, just most recently, when I was at CROI, I noticed that the bictegravir study, so studies of the new integrase inhibitor, have been conducted. So they have conducted a women-only bictegravir studies. So it is becoming more and more common to see pharma conduct women-only studies, which I think is something to be embraced. Another important step is the presentation of gender disaggregated data. It's really frustrating when you go to conferences and you don't see outcomes reported by gender. IAS for quite some time now has asked for gender disaggregated data. CROI only this year, in a move that I think we should welcome, has now stipulated that where possible, researchers need to present their data disaggregated by gender. So it means we can start teasing out differences between men and women. And I think there is an increased focus on HIV in women. Next slide. So I really want to highlight SWIFT. So SWIFT is a knowledge network based in the UK and Ireland, which aims to bring together people from all sectors. So members of the community, HIV clinicians, academics from all different spheres, people who are interested in HIV research in women. And what we do is we are brought together to try and promote research to improve the lives of women living with HIV. And we have seminars where we really focus on gaps in evidence for women living with HIV and try and take this work further. Next. So, what do we know works in terms of improving participation? So I'm back to asking my friends again. Next slide. So what do my friends say? So the meaningful involvement of women with HIV in the research process is absolutely fundamental, and I'm going to go back to that towards the end. It's really important to ask questions that matter. And that means involving women with HIV right from the start. When you're formulating a research question, you need to think, is this question important to women? If it is, then they're likely to participate. We need to work towards improving community research literacy, so improving awareness of what HIV research is and what the benefits are. And we have to address the logistical barriers. That means we need to upfront have funding to be able to support flexible clinic hours, transport costs, and childcare costs. Next slide. And I'm just going to throw this slide in just because I think this is interesting and something to mull over. So this is a paper that was published in Nature Human Behavior last year. And interestingly, this paper reports a link between the gender of the research author and the attention to gender and sex analysis. Basically, you will find if research is led by women and authored by women, female researchers are much more likely to be more sensitive to the gendered and sex analysis in their research. So again, it's thinking about changes structurally from top to bottom at all levels, and thinking about not only addressing barriers to research amongst women living with HIV, but trying to also get more women researchers into the arena, leading the setting the agenda. Next. And really, I want you to think about this statement. So this was something that was said to me by Alice Wellborn, who's the CEO of Salamander Trust, is very, very prominent HIV activist with many years of experience in this area. And she's an academic that specialises in women's participatory research. And Alice says that participation is not just being on the end of a survey or in a trial. Next. So I think this is a really lovely diagram. This is from the International Community of Women Living with HIV, and it's the participation tree. and I'm sure you can come back and look at it in detail in the future, but really it's trying to encourage us to move from tokenism in research, where you may just invite one woman to a round table or to an advisory group, to a model of co-production or community-led research. That's what we should be aiming for, where we either working in partnership or supporting women living with HIV to conduct the research themselves. Next. So what is co-production? So co-production is where researchers, practitioners and the public work together and share power and responsibility from the start to the end of the project, including the generation of knowledge. So this is guidance from the UK's National Institute for Health Research. They published this earlier this year, and it's really just to highlight that co-production of knowledge is increasingly being recognised as a pathway to better science and better research. Next. And finally, what are the research priorities? So we're back to asking friends. Next. So these were the research priorities that were sketched out to me. PrEP in pregnancy. Does U equals U apply to breastfeeding? What are the effects of ART on children of women with HIV? What about the use of ART in pregnancy with contraception and during menopause? What are women's priorities around ART? And what are the social and behavioural outcomes in studies? It's really important to remember that these priorities will get overlooked unless you involve women in HIV research. These things will not be looked at. Next. So this is really my model in terms of how can we improve participation of women in HIV research, and this is adapted from a model in a paper by Gruetal with some things that have been added by myself. So at the level of study design, firstly, we just need to ask ourselves the question, could this be different in women? Could this experience be different in women? Could these side effects be different in women? Could the rates of comorbidities be different in women? If we ask that question right from the start, we will go some way to addressing researcher bias. We need to really address researcher bias. We need to raise awareness amongst the academic community that this is an important issue. We need to carefully consider whether we need to have such strict exclusion criteria. Do we really need to be excluding women who are pregnant? We might have to in some studies. Do we need to do it in all studies? We need to select our sites carefully, to work with the community to find the sites where we're more likely to recruit women. I think we need to give serious thought to quotas to actually have a certain proportion of studies, a certain proportion of participants have to be women in a study. And I think where studies have been done, for the researchers to present disaggregated data. In terms of community engagement, we need to work with the communities to set the research agenda, to help us recruit, to involve communities from design to conduct, and to improve research literacy. Structurally, we need to think about financial support, childcare, flexible hours, and strong community partnerships. And at policy level, we need to be scrutinising all proposals for gender bias and monitoring recruitment. Next slide. So, to conclude, women are more than half the global population of people living with HIV. They are underrepresented in HIV research. This underrepresentation of women is going to lead us to bad science. And I would argue that the underrepresentation of women is unethical. We need to address policy, structural and community factors, and most importantly, we need to be working in partnership with women living with HIV to produce the highest quality research. Next. So I'm just going to leave you with this last slide. So this is Paula Johnson, who is an amazing professor in Boston, who has really been leading all the research on gender bias in healthcare for about 20 years now. She gave an amazing TED talk, and I put the link on here. I would really just recommend that you go and listen to her talk. It takes 10 minutes and it's fantastic. And what she says is, don't leave women's health to chance. Next. So I'm going to end there. I could not have prepared this lecture or this webinar without the help of friends, and I also want to acknowledge the EATG for thank them for inviting me to give this webinar. acknowledge my funders who are funding research in women living with HIV, and most importantly, to acknowledge the contributions of my participants and patients who I really have learnt so much from. Thank you.
Thank you very much, Shema, for this. I mean, no, personally. And I have a lot of questions. I know we already have questions. We already had questions before we, I mean, the participants have submitted questions with the registration. Could we take this time, basically, can I ask for some clarification personally? Are we really saying, because that hasn't registered with me, are we really saying that the best way that we have right now to learn if a medication is effective or if it has adverse effects on women is by the reports that we have after the medication is in circulation?
So it depends on what medication we're talking about. So certainly with the early antiretroviral therapies, the majority of those studies will have been conducted in men. And so we are basing what we know about side effects on side effects reported after those antiretroviral therapies were widely in use, but often side effects will be reported, but they may not be reported by gender. And that's why I say this new move towards pharmaceutical companies funding women-only studies or studies where they're comparing men and women is really important, because for years we've seen drug trials where it's 90% men, and that is not that is nowhere near good enough in being able to tease apart these important differences.
And also, is there a cost involved with women's participation? Is the cost being increased for some reason, or is this a myth?
I don't think it's much more expensive. I mean, yes, I do think you need to provide funding, as I say, for flexible clinic hours, maybe reimburse childcare costs, reimburse travel costs. These aren't huge costs when you're thinking about drug development. So I don't think the main barrier is financial. I think it's partly just having to make a paradigm shift in people's thinking to get them to think about equal representation of women, and to try and bust the myth that women don't want to participate in research, because many do. But I think also it's about, as I say, addressing the community level factors and working to improve research literacy amongst communities.
Thank you very much for that. Eliane has a question for you, so we're going to unmute your mic.
Hello.
Hello.
Hi.
Eliane, can you hear you? Eliane, can you unmute your mic? It should be on the right-hand corner. Eliane, we cannot hear you.
Hello?
Eliane, can you hear us?
Yes, I can. I hear you.
Okay, fantastic.
Oh, hi.
Hello? Hi.
Hello.
We can hear you now too, so we can have your question.
I was I heard about the research with the problems women with the other diseases like heart and cancer, but I was also more concerned about like do you do also research with the diabetes, because it's also a very common disease, and which is also affecting also women? And another question was about, do you also in more research, are you involving also like African community background people?
Okay, I can thank you for that. Thank you for those questions. So
Thank you.
I can take, so the first question in terms of diabetes, I can't really comment on because diabetes is outside of my area of expertise, but I would assume that if we're seeing that this pattern of women not being represented in research is probably the same in most long-term conditions, but I can't say with confidence that you're seeing this same underrepresentation in diabetes. In terms of research with African communities, so I can just speak from my own experience. So my work is all conducted in the UK, but I work pretty much exclusively with women living with HIV. 80% of the women that I work with are from African communities. So although it's really important to be aware of the effects of ethnicity and culture and also socioeconomic status in terms of research participation, I've always found it relatively straightforward working or recruiting women from African communities into HIV research. But that, I think, is largely because I work in very close partnership with some amazing HIV organisations. So, for instance, Positively UK have been an extraordinary source of support and a partner for me in much of the work that I've done. And I think that that's critical, really, in helping me be able to do the work that I've been able to do.
Okay, thank you.
Shema, is it all right to keep you for a few more minutes to answer a couple of questions?
Very happy to stay on the line.
So Ivan Martinez is asking where the circle framework is, the one with personal factors, societal factors, and structural factors that you used with the 4 circles.
Okay, sorry. Yep.
Christian is trying to show it now.
Yes, so what about this?
One. Where is it from?
Oh, sorry. So, if you look up social ecological model of health, you can just Google it. There are lots and lots of papers on this. And I just used that framework to construct this myself for women living with HIV. So this particular diagram is my own, just thinking through what I know to be factors that affect women living with HIV. But the model itself, if you look up social ecological model, you will find it. And I'm happy to send I'll try and send a reference to Christian so he can share it on the EATG page.
Perfect. Thank you very much for that. We have another question from Jackie, who is asking if there are any clinical trials that specifically focus on long-term effect of ART on postmenopausal women with genetic tendency to comorbidities in aging.
Oh, that's a fantastic question. That's in my favorite research area. No, is the short answer. There has been very, very little work looking at menopause and HIV. So the PRIME study, which I lead, is one of very few. And I think the PRIME study and work that's being done in Canada and also some work in the United States is really beginning to raise the profile of the importance of menopause for women living with HIV. We're not at the stage where we're specifically looking at antiretroviral therapy in menopause. There have been a couple of studies that have looked at response to treatment in pre and postmenopausal women living with HIV, and they've seen no difference. A couple of studies that have looked at drug concentrations, antiretroviral concentrations in pre and postmenopausal women. Again, they haven't found any difference, but I'm talking about a handful of papers. I think there's increasing interest, certainly in terms of comorbidities. I think that's how to get pharmaceutical companies involved, because they have an interest in long-term comorbidities and side effects of their medication. And I think increasingly they're becoming interested in women living with HIV post-menopause who may have a whole host of risk factors for comorbidities. So watch this space, basically. I think it's a growing area.
So we have another question about the hormones and PrEP efficacy in trans and cis women, as well as trans men assigned female at birth. What are the regulations around including women and female-bodied people in HIV research as participants and investigators? And who are the top names in PrEP research as women researchers and around women and their bodies in PrEP research?
Okay, so I think that was a few questions. So there's something about PrEP and women, and then something about regulations around women and trans women in research.
Yes,
and was there
as
something
participants
else?
and investigators, and who are the top names in PrEP research as women researchers?
Okay, so firstly around PrEP, I have to put my hands up and say that I'm not an expert when it comes to PrEP, so I can't recommend the specific names in terms of PrEP and women or female investigators. I would say that the big PrEP studies in women were Partners in PrEP, FemPrEP and Voice. So these are the major studies that have looked at PrEP in women. So I would recommend that you have a look at papers by those teams, because they are likely to be producing the most amount of work in this area. The other person who I think writes really well on HIV and women and PrEP is Judith Auerbach, who's a social scientist academic. But yeah, it's not my area of expertise, I'm afraid. In terms of regulations around both cis and transgendered women and trans men participating in research, there aren't really any regulations, to be honest. And I'm not sure it's something we can regulate, except to say that I think we need to be mindful of the need to include women, and that means cis women, trans women, and also to include trans men who are assigned female sex at birth. I think these things are hard to regulate. To be
honest, sorry to interrupt, I'm hoping that this project will not regulate, obviously, but will encourage a discussion around this issue with different stakeholders. So I'm hoping that through this project we will begin a process of at least putting this on the table.
Absolutely. And in terms of regulations around female investigators, that doesn't exist either. And again, I think it's quite hard to practice. Yeah, as Christina says, the important thing is to have this discussion, to raise awareness and to bring people with you rather than to regulate, is my feeling. I think if we can show, certainly with drug companies, if we can show that including women leads to better trials, they will come with us, and they are already. And I think that's the way to do it. And I think the more we embed women's participations and trans women's participation and trans men's participation in research, the more we embed that into practice, the more it will become just normal.
Thank you very much, Shema, for answering the questions. There are some more questions, but I think they're more related to how we could network better, to how we could advocate better, to how we could build networks of collaboration in order to keep bringing up these issues. And I think there are several initiatives right now, like SWIFT or like this project. We're happy for anybody to contact us with any proposal or just to make a contact. Oral contact details are in the presentation anyway. Or you can check our website, EATG4women.com. We have contact details there as well. We have information there. we will be happy to answer any questions that you might have. So I would like to thank you very much for your time, Shema. This was an amazing presentation. I have enjoyed so much. And thank you everybody for participating. Thank you everybody for staying longer to answer questions. And I think we can call it a day. We'll be very happy to see you in our future webinars.
Thank you. And thank you very much for inviting me to contribute to this great project.
Thank you. Thank you all so much.
Okay.